Picture a man we'll call Gerald. 71 years old, retired, still sharp, still mowing his own lawn every weekend, still driving himself to his Tuesday poker games. His wife finally convinces him to go in for a physical he's been putting off for 2 years. The doctor looks him over and says, "Everything seems fine." Then adds 6 words that change the direction of his life. "Let's just run a few tests." 3 months later, that same man is recovering from a procedure he never needed for a condition that would never have harmed him. He's dealing with complications that have nothing to do with why he walked into that office. And the version of his life that existed before that appointment, the lawn, the poker games, the independence, that version is gone. That story is not rare. It has a name in the medical literature, and today we're going to talk about it honestly. My name is Dr. James Anderson. I specialize in cardiovascular health and the biology of aging, with a particular focus on how the body's circulatory system changes after 60 and what that means for the medical decisions we make. The pattern I keep encountering in my work with adults over 60 is this: people who felt completely well before a routine appointment and came out the other side managing something they did not have before the testing process began. That pattern has a mechanism, it has a name, and once you understand it clearly, you will never sit in a doctor's office quite the same way again. Here is the number that deserves your full attention. Estimates in the medical literature suggest that between 15 and 25% of all medical procedures performed in the United States each year are unnecessary. But here is what almost no one discusses. That percentage rises sharply after the age of 65, not because older patients are sicker, but because the risk-to-benefit equation changes fundamentally after 65. And the current medical system was not designed to calculate that equation during a 15-minute appointment. There is something called the cascade effect. One routine test finds a small abnormality. That abnormality triggers a follow-up scan. The scan recommends a biopsy. The biopsy points toward a procedure. The procedure causes a complication. And a person who walked in feeling fine is now managing a medical situation they did not have when they arrived. The cascade does not begin with the surgery. It begins with the first test. And that is exactly what today is about. I'm going to walk you through 5 specific medical checkups that I would personally reconsider after the age of 65. Not because medicine is broken, but because after 65, the risk-to-benefit equation changes in ways that most physicians do not have adequate time to discuss with you during a standard visit. I'll explain why the equation shifts, share what I've seen happen to real patients, and give you a set of specific questions at the end of this video that can completely change the dynamic in your next appointment. Stay with me through all 5. Number 3 is the one that surprises people most, because it involves a test that sounds like pure common sense. And number 1, the final checkup on this list, is the one almost nobody is questioning right now, even though the data behind it is more troubling than almost anything else I'm about to share. Before we begin, there is one concept you need to understand, because without it, nothing else I say today will fully land. I call it the longevity lens. Here is how it works. When you are 50 years old, routine screening is often one of the best investments you can make in your health. You find a problem early, treat it, and potentially gain decades of healthier life. The math is clean. The investment pays off. After 65, 3 specific things change that equation entirely. First, many of the conditions that routine screening identifies in adults over 65 will never actually cause harm. They grow slowly, produce no symptoms, and in a significant number of cases, the person will outlive them completely. But once a result appears on a medical report, medicine does not have a leave-it-alone option. It has a treatment button, and that button gets pressed. Second, your body's tolerance for medical intervention is not what it was at 50. A surgery a 58-year-old recovers from in 2 weeks can mean months of difficult recovery for a 73-year-old, along with complications and a quality of life that looks very different afterward. Third, there is the cascade effect. One test, one abnormality, one chain of events that started from a position of feeling perfectly fine. Hold the longevity lens in your mind as we move through every item on this list. Let's begin with checkup number 5. Routine PSA prostate testing after the age of 70 in low-risk men with no symptoms. This one requires precision because it is easy to misunderstand. I am not saying prostate cancer is not serious. I am not saying PSA testing has no value. What I am saying is that for men over 70 who have no symptoms, no family history of concern, and no prior documented issues, the data on routine PSA testing tells a story most men have never been given the chance to hear. Here is the core problem. A PSA test can detect a prostate cancer that is, biologically speaking, barely moving. A slow-growing tumor that, if left completely undisturbed, would never spread, never cause symptoms, and in a 71-year-old man would almost certainly never shorten his life. He would live with it, not from it. But the moment that result comes back elevated, medicine rarely waits. Biopsies are ordered, specialists are consulted, treatment options are presented, and for a man who is 71 and otherwise healthy, treatment for low-grade prostate cancer can mean radiation, hormone therapy, or surgery, each carrying real risks to continence, sexual function, energy levels, and overall quality of life. The American Cancer Society updated its guidance specifically because of this pattern. For older men at average risk who have no symptoms, the risks of finding and treating a slow-growing cancer frequently outweigh the potential benefits. I want to tell you about a patient I'll call Arthur. 74 years old, retired contractor, physically active, no family history of prostate cancer, and absolutely no urinary symptoms of any kind. His routine PSA test came back slightly elevated during an annual physical. A biopsy confirmed a low-grade, slow-moving prostate cancer, a Gleason score of 6, which in clinical terms represents the most indolent end of the prostate cancer spectrum. His urologist recommended radiation therapy. Arthur trusted the recommendation and proceeded. Within 8 months, he was dealing with chronic fatigue that disrupted his mornings, urinary urgency that altered how he structured every day, and a quality of life that had declined in ways he had not anticipated. When he sat with me a year after treatment, the words he used were precise. "I felt better before they found it than I do now that they fixed it." That sentence is not unique to Arthur. It appears throughout the medical literature with a consistency that should give every man over 70 genuine pause before automatically agreeing to a routine PSA test. If you have urinary symptoms, hesitancy, changes in flow, increased nighttime frequency, talk to your doctor. Those symptoms matter and change the equation. If you have a strong family history, that matters too. But if you are over 70, have no symptoms, and are considered average risk, the conversation with your doctor should not simply be whether to screen. It should be, if we find something, what would we actually do about it? And would that treatment genuinely improve my life more than carefully monitoring the condition? Now let's move to checkup number 4, routine bone density DEXA screening followed by automatic long-term medication. Before anyone misreads this section, osteoporosis is real, and falls are genuinely devastating for older adults. I want to be precise here because there is an important difference between questioning a test and questioning the automatic treatment pathway that so often follows it without adequate conversation. A DEXA scan measures bone density. When results show low bone density, many physicians immediately prescribe medications known as bisphosphonates. You have likely heard the brand names in advertisements. The message delivered is simple. Low bone density equals medication, and medication equals protection. But here is what that message consistently leaves out. Long-term bisphosphonate use, particularly beyond 5 years, has been associated with a rare but serious condition called atypical femoral fractures. These are stress fractures of the thigh bone, the very bone the treatment was prescribed to protect. These fractures can be severe, often require surgery, and in some cases create more disability than the fractures they were originally meant to prevent. There is also a condition called osteonecrosis of the jaw, involving deterioration of jawbone tissue that can be painful, difficult to treat, and in some cases triggered by the very medication intended to strengthen the skeletal system. Meanwhile, and this is the part that belongs in every conversation about bone health, the single most consistently effective intervention for reducing fractures in adults over 65 is not necessarily medication, it is fall prevention and balance training. Research on Tai Chi specifically has demonstrated a reduction in fall risk of nearly 50%. Removing tripping hazards from the home, installing grab bars in bathrooms, reviewing medications that may be causing dizziness, having vision tested annually. These interventions often reduce actual fracture risk more meaningfully than medication, and they do so without any drug-related side effects. Let me tell you about a patient I'll call Helen, 72 years old, a retired music teacher. After her annual physical, she underwent a DEXA scan and was told her bone density was below normal for her age. Her physician prescribed a bisphosphonate that same day and advised her to continue it indefinitely. Helen came to see me 3 years later describing persistent aching deep in her thigh. Further evaluation identified an early atypical stress fracture. She had never fallen. She had no history of broken bones. She was taking medication specifically intended to prevent fractures, and her bone was reacting adversely to that very treatment. Before automatically accepting a medication recommendation following a bone density result, ask your doctor this: what is my actual fracture risk based on my complete health profile, not just this scan? And how does the benefit of medication compare with a structured fall prevention program? That question is not confrontational. A good physician should genuinely welcome it. Now let's come to checkup number 3, the one that surprises most people: routine cardiac stress testing in individuals without symptoms. This sounds so responsible on the surface. Your doctor says you are 68 years old and they would like to make sure your heart is doing well. You get on a treadmill or receive a medication that temporarily stresses your heart while they monitor the response. What could possibly be concerning about that? Here is the problem that rarely gets mentioned in the room where the decision is made. Cardiac stress tests performed on people without symptoms, no chest discomfort, no unexplained breathlessness, no dizziness during physical activity, can have false positive rates approaching 40% in certain populations. That means that in nearly half of those cases, the test identifies an abnormality even when the heart is functioning normally. But medicine cannot simply set aside an abnormal finding. That false alarm typically launches the next phase of the cascade: cardiac catheterization. A thin tube is guided through your blood vessels, usually through the wrist or groin, directly into the heart. The risks include bleeding, blood vessel damage, heart rhythm disturbances, and in rare cases, the catheterization itself can trigger the very cardiac event the screening was supposed to prevent. And if the catheterization finds a partial blockage, which is extremely common in adults over 65, many of whom will live for decades without a single cardiac event, you may be advised to receive a stent. This is the part I want you to hear with particular care. Multiple major clinical trials, including the widely cited ischemia trial, found that placing stents in patients with stable coronary artery disease did not reduce heart attacks or extend life when compared with medication and lifestyle management. The stent did not outperform a daily 30-minute walk combined with appropriate medical therapy. It carried all of the procedural risks and frequently required years of blood-thinning medication afterward. So the cascade often looks like this: feeling fine, routine stress test, false positive, cardiac catheterization, stent placement, blood thinners, ongoing monitoring, no statistically meaningful improvement in long-term outcomes. That is the complete picture. And it all began because someone said the words, "Let's just check." If you have no chest discomfort, no unexplained breathlessness, and no dizziness during physical activity, the primary conversation with your doctor should not focus on stress testing. It should focus on optimizing the factors that genuinely drive cardiovascular risk: blood pressure, cholesterol, blood sugar, physical activity, and sleep quality. That is where the real cardiovascular gains live after 65, and none of them require a catheterization to achieve. Now to checkup number 2, the one almost nobody is discussing: routine carotid artery ultrasound in patients without symptoms. Based on what the evidence actually shows, the silence around this particular test may be one of the most consequential oversights in routine senior healthcare today. A carotid artery ultrasound examines the large vessels in the neck that carry blood to the brain. The logic sounds airtight. Find a blockage before it causes a stroke, remove it surgically, problem prevented. But the reality is substantially more complicated, and for people without any symptoms, potentially more dangerous than the rationale suggests. Here is the fact that reframes everything. The surgical procedure used to treat significant carotid artery narrowing, called a carotid endarterectomy, carries approximately a 2 to 3% risk of causing a stroke during or immediately following the operation. In older adults with additional health conditions, that risk may climb higher. The United States Preventive Services Task Force, widely regarded as the gold standard for screening recommendations, specifically advises against routine carotid artery ultrasound in adults with no symptoms. Their conclusion is direct. For asymptomatic individuals, the risks of intervention generally outweigh the potential benefits. Here is why this matters so much in practical terms. A substantial proportion of adults over 65 have some degree of carotid artery narrowing. In many cases, that narrowing has been present and stable for years, producing no symptoms and causing no problems. But when routine screening detects it, a well-intentioned specialist may recommend surgical correction. The problem is that operating on a blockage that was never symptomatic can dislodge a small fragment of plaque that travels directly to the brain. The intervention ends up producing the very outcome it was designed to prevent. If you have no neurological symptoms, no sudden vision changes, no facial asymmetry, no arm weakness, no brief episodes of confusion, no slurring of speech, routine carotid artery screening is generally not supported by the evidence as a priority. Direct your attention instead toward the factors that genuinely reduce stroke risk. Blood pressure control, which remains the single most important modifiable stroke risk factor. Blood sugar management, atrial fibrillation management if it applies to you, and consistent physical activity. However, if you experience any of the symptoms I just mentioned, even briefly, even if they resolve completely within minutes, that changes everything. Seek evaluation immediately. At that point, we are no longer speaking about routine screening. We are talking about your body sending an urgent signal that demands prompt attention. Now we arrive at checkup number 1, routine colonoscopy after the age of 75 in low-risk, asymptomatic adults. This is the one most people have never heard questioned because colonoscopies have been so thoroughly endorsed for so long that challenging them in the appropriate clinical context can feel almost counterintuitive. But the data for adults over 75, specifically those with no symptoms, previously normal colonoscopies, and no family history of colon cancer, tells a different story from the one most people have been given. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening in average-risk adults over the age of 75. Their reasoning is specific. The risks begin to outweigh the benefits, and those risks become very real when you understand what can happen. A bowel perforation, an actual tear in the wall of the colon, occurs in approximately 1 in every 500 colonoscopies. For a younger adult, that may be a manageable surgical complication. For a 77-year-old, it can mean emergency surgery, a colostomy, extended hospitalization, and a recovery process that permanently alters independence and quality of life. That risk does not even account for the preparation itself. The bowel cleansing required before the procedure can cause dangerous dehydration, electrolyte imbalances, and significant cardiovascular stress in older adults. There is also the risk associated with sedation, which increases meaningfully with age. And here we return to the longevity lens. The colon cancers most likely to be discovered in asymptomatic adults over 75 tend to grow slowly. Slowly enough that in many cases they would never cause meaningful harm during that individual's remaining lifetime. Let me tell you about a patient I'll call Frances. 78 years old, a retired school teacher. She had completed 2 colonoscopies during her 50s and 60s, both entirely normal. No polyps, no family history, no symptoms of any kind. Her new primary care physician reviewed her chart and told her she was overdue for another screening. Frances asked questions. She was reassured that it was routine, so she agreed. The preparation affected her severely. By the following morning, she was confused, physically weak, and barely able to stand. Her daughter brought her to the emergency department before she ever reached the procedure itself. Her electrolyte levels were critically low, and her heart was under significant strain from dehydration. She spent 5 days in the hospital. She never underwent the colonoscopy, and the testing conducted during those 5 days revealed that her heart and kidneys had been placed under a stress that her body was not equipped to handle, all from a preparation process for a screening she did not meet the criteria to need in the first place. So what should you do instead of routine colonoscopy after 75 if you are low risk and without symptoms? Ask your doctor about non-invasive stool-based tests such as an annual FIT test or a test like Cologuard. These options can identify genuine warning signs without exposing you to procedural risk. And if you do have symptoms, blood in your stool, unexplained changes in bowel habits, that changes the clinical picture entirely. See your physician promptly. Symptoms require evaluation regardless of age. Here now is something you can take with you into every future medical appointment. 5 questions that can change the entire dynamic of the conversation. Write them down or keep them somewhere accessible. The first, what is the false positive rate of this test for someone my age? This tells you how likely an abnormal result is to launch a chain of follow-up procedures, even when nothing is actually wrong. The second, if this test finds something, what are the realistic treatment options for someone with my age and overall health picture? This moves the discussion toward real outcomes rather than hypothetical findings. The third, what is the actual procedural risk of any treatment we would likely pursue? Most people never ask this before agreeing to a test, but every procedure carries risk, and you are entitled to know what that risk is before the cascade begins. The fourth, what happens if we choose careful monitoring rather than immediate treatment? For many conditions found in older adults, watchful waiting with consistent follow-up is not just acceptable, it is often medically superior. The fifth, what is the most effective non-invasive approach for this condition? Because as we have seen today across bone health, heart health, and stroke prevention, lifestyle and medical management frequently outperform procedural intervention with significantly less risk attached. Any physician who is genuinely serving your interests will welcome these questions. They will respect you more for asking them. And if a doctor makes you feel like a problem for raising them, that reaction itself tells you something important about whether that physician is the right fit for your care. I want to leave you with this thought. There is a real and meaningful difference between medicine that finds things and medicine that helps you live well. After 65, the purpose of your healthcare should not be to generate more findings. It should be to protect your quality of life, your independence, your energy, and your ability to spend your days doing what genuinely matters to you. The physicians I most admire understand that recommending less sometimes requires more wisdom than ordering another test. That choosing careful monitoring over immediate intervention can demand more professional courage than writing another referral. You have the right to ask what a test is looking for. You have the right to understand what happens if it finds something. You have the right to know whether a finding would be treated and whether that treatment would actually improve your life. Medicine has given us extraordinary tools, but tools only help when they are used in the right context, for the right person, at the right moment. You are that person, and you deserve care that is built around your life, your values, and your actual health, not around a checklist. If this video gave you a new framework for thinking about your health after 65, consider sharing it with someone you care about who is navigating these same decisions. And leave a comment telling me which of these 5 checkups surprised you most. I read every one, and your response often shapes what I cover next.